Started. Good afternoon. It's a pleasure to be with you today. I'm Istvan Camargo, head of innovation at the Sabin, and that's where I'm at right now. That's why I'm wearing a mask. I apologize for that. Our conversation will be about access and impact. So, why are we going to talk about that in the context of digital health? They're highly connected, these two subjects, and highly connected to digital health. Back in 2011, I was in the United States when people were starting to talk about digital health. And back at that time, access was already a hot topic. Back then, we did not talk about artificial intelligence or virtual reality. It was simply the internet. And that's what people used to say, that the internet would broaden the scope of health and that we would be able to broaden access without necessarily having to increase costs. 10 years have gone by, many initiatives have occurred, and I think that there are a few solutions that are really meeting these needs and fulfilling this purpose of digital health, which is to broaden access and cause more impact. We have with us today two representatives that are two founders that are representatives, Jamil from WeCare and Rafael from IC Labs. Before we start talking about this subject, I would like for each one of them to introduce themselves, starting with Jamil, please. Thank you, Istvan, and good afternoon, everybody. So for the second year in a row, we're participating in the FIS initiative. Thank you for the invitation. This is a great week. I was able to see many longtime friends like you, for instance. I am Jamil Cade. I did 3 medical residencies at the University of Sao Paulo, and I became an entrepreneur in 2014, working on projects with an impact on healthcare, mainly focusing on telemedicine in acute heart attack in Sao Paulo, where we were able to refer over 1,000 patients over the course of 3.5 years of a project to catheterism, which is the gold standard with an impact on mortality reduction and costs. And that's where I started becoming engaged in the creation of WeCare, which is a startup. So once again, thank you very much, Istvan. I'll give the floor back to you. Thank you, Rafa, for being with me in this panel. I have a deep admiration for you. Thank you, and thank you for accepting our invitation. We know that you're extremely busy, so thank you very much for dedicating some time to this conversation with us. Rafael, could you tell us about yourself and ICI Labs, please? Sure. It's a pleasure to be here with you, my longtime friends. It's a pleasure to participate at the FIS. I've been here in past years. I'm Rafael Oki. I'm a founder of the Solvirus.com social project that then originated the Saving Lives, which I can tell you more about. I'm an engineer. I studied in France for 2 years. Then I went to the MIT And I have, with the purpose of specializing in supply chain, there's a global problem related to the lack and waste of blood. And we currently work with the main blood banks in Brazil. We're also expanding our operations to the United States with the purpose of saving lives using data science. So in a nutshell, that's what I do. And I can elaborate on that later if necessary. That was perfect, Rafael. Thank you. You said that you studied in France and at the MIT, like you went to the corner and came back. But anyway, we're going to be exploring your experience, and Jamil is also highly experienced. Anyway, I want to start by asking you a few questions. First to Jamil. Jamil, how do you help in pre-hospital care, and how can you cause an impact on health outcomes? Thank you. Well, We Care is a startup that works in urgencies and emergencies in a pre-hospital setting. So we create solutions to automate the process involving the patient journey from end to end, whether it is in a primary unit, secondary unit, an ambulance, and that allows us to screen patients for severity based on international protocols and immediate guidance of what to do based on clinical severity, according to the information that we get. We are in an integration with multi-parameter monitors that capture these data regardless of where the patient is. And with that, we're able to automate the process and do a risk assessment. And we can also regulate for services with the necessary technical and human resources that are required to help these patients. We know that the main causes of death, we have physical trauma below 45, heart attack above age 45. So our goal was to allow these people to be helped by healthcare professionals with a mobile device through tablets. And by entering data or capturing multi-parameter monitors, we wanted to be able to assess them for risk and which georeferenced hospitals would have the adequate resources, and letting hospitals know that the victim is about to arrive, and also allowing them to see physicians if they're our customers, or We Care customers if the customers do not have their own physicians, which is a recurring thing in this market. And at the same time, Istvan, we capture the same metrics, the places that the patients are referred to based not only on geolocation, but also clinical data, generating data and metrics in real time about a sector that's never had this type of data, which is the pre-hospital sector. Thus far, what we've had is based on paperwork, pen and paper, or voice call over the phone. So we basically automated the process and digitalized the process for our customers or for their physicians to be able to better serve them. We've always thought that our journey in terms of impacting health, reducing costs, and death rates made a lot of sense, because these patients, when they're hospitalized, if they're referred poorly, incorrectly, the expenses will be at least 6 times higher. We're talking about public and private healthcare scenarios, which are the hospitals that these customers get sent to. So we wanted to have an impact on health in terms of reducing costs, reducing by reducing inadequate transportation by 40%, optimizing time by 30%. And when patients are referred, they're referred within a much shorter time frame, and they consume fewer resources. So they also spend less, on average, 20% less than patients going to different hospitals. WeCare has in its DNA, a DNA of data science in all of our processes. So now we are setting up heat maps of events based on geolocation, based on clinical data, and we're creating predictive models of where the urgencies and emergencies are going to occur in the cities where we're at, so that our customers are able to better serve these victims, whether they're inside a primary unit, a secondary hospital, in a verticalized chain, or a health insurer, or even the companies that operate ambulances and rescue vehicles. And we endow them with a module. And we thought that that was our role and our purpose. After the pandemic hit us, we also started working with elective teleconsultations, focusing on regulation. So currently our solution for elective medical visits, they're also applied to some pre-hospital customers. We're also focusing on telemedicine booths with the Flex Medical teams and other ongoing projects, some of them in partnership with Sabin. So our intention is to, I wanted to tell you about, this is basically what we do. So thank you for the opportunity. Oh, thank you. That was brilliant. I think your value proposition is unique. The healthcare business is not really global. Some solutions that you see in some countries do not work in others due to regulatory aspects, or even the clinical profile of each country. And due to that, I think that health tends to be a sector that will be at the leading edge of innovation. Like we see that in other industries, there's copycat type of behavior, solutions that people see abroad and end up replicating in Brazil. But due to the circumstance that I told you about, that involves the healthcare department, I think that we can really be really innovative. And WeCare is really an example of that. So congratulations. We'll talk more about that solution. And now I would like to hear it from Rafa. How can you help blood banks avoid shortage and waste of blood? Thank you for the question. Well, I created the initiative back in 2016. My grandparent needed a transfusion, and my fiance, back then she was my girlfriend, she would have to go to a neighboring city, travel 100 kilometers to donate. And I asked her, well, why are you going to do that and donate in another city? And she told me that, well, because they need my blood type over there. I saw it on a social network. Well, it would be much more intelligent if we had a record of people interested in donating, and we could invite those people according to the need and or blood type, and engage these people to donate according to need, because it's a chronic problem. We see that every month. With the pandemic, it got worse. So that's when I created the salvevidas.com as a social project. Then it started growing. I had created a startup in France for digital marketing. So I thought, well, with my technical knowledge, with my marketing knowledge, I think I can help blood banks. But I started seeing that the problem is much worse than it seems. It's not only about taking donors or taking the correct blood type. The blood banks also suffer with waste because of the expiration date, and people are sometimes not aware of that. And this problem is so complex that it is a global problem. As Istvan said, right now, this is one of the very few problems that is probably general. The entire world suffers from that problem. And I ended up specializing in the MIT with this goal to understand how we could keep adequate stock levels at blood banks, given the need to have altruistic donors that simply go donate because they want to. And I thought, well, can I apply this knowledge about digital marketing and production and supply chain technology, computers, and then it came data science to solve this problem. And we hadn't had a systemic solution for it. So we created the Save Lives startup, the Save Lives company, with investments from Albert Einstein and other angel investors. And over the course of these years, we started expanding the solution. And as I said, we serve most of the blood banks that represent almost 20% of all collections in Brazil. And we've been developing solutions for the United States. We see that that's a global problem. It's not restricted only to Brazil. And we have the benefit, quote unquote, of being a program where this is standardized all over the world. The blood bags are a standard, and this makes it easier for us to create value for blood banks in other countries as well. So we help blood banks through salvevidas.com. From a social perspective, it's free of charge, where we invite donors to register, and we invite registered donors to go donate according to the need for their blood type. And on the other hand, Saving Lives also helps blood banks using data and bringing data to life, and that's used to decrease costs and improve operations and improve the entire workflow, empowering the entire operation. So that's how we help the blood banks save more lives, and with the donations of these altruistic people. And at the end of the day, they are the ones that make a difference. That's fantastic. So you started with a simple statement. You told us about your girlfriend's story, and then you went deeper and deeper into this context and started finding out things that you probably never imagined before. Usually that's how it works in the healthcare industry. We have ideas that may sound simple, but in sounding simple, they still have a huge impact. If you have to over-explain what they do, they're usually not interesting. So congratulations, Rafa. And going back to Jamil, you said that you're a physician, an existentialist doctor. So how did you transition to that?
The question is excellent, and the answer is super difficult, because I've been trained as a doctor. As I said, after I had 3 medical residencies in Sao Paulo, I did my PhD in cardiology, the Federal University of Sao Paulo. But when I joined in 2014 in a pioneer project of telemedicine for acute infarction in the East zone of Sao Paulo, we were a benchmark then in 17 cities and 13 other countries in addition to Brazil. And I ended up understanding the fact that we could impact and make an impact to health. We could care for many more patients than just going to the hospital and doing catheterism during an infarction, for example, and this kind of intervention. So I spent 17 years in the emergency ER with Albert Einstein, etc. And at the same time, I saw the patients when they would arrive, they would come from other units, from other locations. So when they were outside the appropriate care window in ER, you have sort of gold hours, and they would come without a clear indication, without clear need, because actually they could have gone to a hospital of lower or smaller ticket. That really annoyed me, because the problem was not that our getting those victims and providing primary care. We had to care for those patients and take care of the whole journey of the patient. And looking at this scenario and experiencing it. I've always been a doctor focused on emergencies. I ended up creating a project in 2018 based on one of those presentations, which was teletrauma, a very nice project that many people actually, and actually I met Rafa at the time at teletrauma in 2018. Then we had a pandemic. We met a few times. It was quite interesting project that we actually decided to provide support to cranial trauma, and we were amongst the 10 best ideas from Stanford in 2018. So we decided that it made sense. So it was a group of Stanford where we had 65 students, only 4 doctors. I thought it would be worthwhile working with that as a president. From then on, we had several experimentations. Team set up. We Care has now 16 up to moving on to 17 associates. And we decided that it wasn't worthwhile talking about physical trauma. It was worthwhile talking about several things, trauma and several things, and regardless whether the victim was from the unit where there were no experts, because many times you don't have a neurosurgeon in basic units, and you have to talk to a generalist for first care or primary care and ambulances and rescue. And we saw that even half the ambulance don't even have a doctor on board. So we understand to the roadmap of the victim, so how they would go to the hospitals and they would actually be referred without the need of referral. We created a screening regulation and support through tele appointments with experts from the very beginning, bringing an impact that was important to us for stroke patients, etc. From then on, I never stopped enterprising. At least at We Care, we know that we have to be entrepreneurs and we have to invest. So, especially with our clients and our partners, and we understand that you cannot say when I stopped being a doctor and I became an entrepreneur. There are two things. These is all together. So entrepreneur, doctor from the very beginning, when we choose the profession, the specialty, where we're going to work, how we're going to manage our scale and our financial part. So the doctor already has that. What I did was obviously to use what I had already experimented with my training and with the teachings of entrepreneurship from Stanford University to create We Care. From then on, we never stopped. You were always there as our mentor in telemedicine. It's a great pleasure to be with you here. Thank you very much. I actually give the floor back to you. Thank you, Jamil. Well, we're talking about the fact that for you to make this transition from medicine to a startup, it was not so difficult because a doctor somehow is an entrepreneur. You're totally right. And now for the engineer, Rafael, what was it like for an engineer to make this transition to the healthcare industry? Great question. Thank you, Istvan. When I chose to take production engineering when I was in middle school, when I thought of my teenage mind, I wanted to set up a company that could help society. That was my motivation to study production engineer. My father is a production engineer, and my description of production engineer is an organization engineer, organizing things production process, etc. So I said, I want to organize people to attain the same common goal to help society. So I'm going to study production engineering. This comes from way back on. But then I decided to see, what am I going to do? So entrepreneurship, and let alone social entrepreneurship. And I thought about setting up a company that could help society. And I took note during college, several ideas. And as I attended classes, I thought about that and preparing for this moment. That's when I left, went to Chile, lived in Canada, and then France. Well, so I shared the story I told you before. But it was through those experiences that I always tried to be connected as to how I could help society. And then in France, I had this opportunity of setting up a startup geared to digital marketing. And then I had that conflict. How come that for years I have this motivation of helping society, and then we get marketing there? It was not very linked to my purpose of helping society. So I said, this is not what I want to do. It's not linked to my purpose. Let me better prepare. In the better prepare and being tuned into what's around. And then I had my grandfather needing and my, say mentioning, well, she said it was not yet a company, it was a social project. And when I saw that problem, that it generated huge costs, the problem to society that is so significant, that's when I managed to marry the teenage dream and setting up a company that could help society to a goal of actually being investing and being an entrepreneur in health. And everything we touch here impacts life. And perhaps it's not that we don't have it. Anywhere we actually invest in society will have great impact to society. That was my trajectory. Fantastic. I remember when I was a teenager, when we wanted to change the world, we would set up a rock band. Today, people set up a startup. It's much more effective. Let me ask Jamil another question. I'd like him to tell us about the products and cases from We Care. Okay, let's go. I like this analogy to rock band because I've always been very bad with musical instruments. The part of the startup is a bit less problematic to me. I think it's easier than playing an instrument. Okay, We Care has experimented several separate products. When I said we created teletrauma, Anya, artificial intelligence. So you can get from ECG with a photography gives you the likelihood of acute heart attack, which is a specific type, more severe type of heart attack or infarction. So we tried another formula with COVID, telecovid. And the fact is that today we have gathered all our know-how and our knowledge basically into two products that we act upon: telecare, pre-hospital care, and it's a platform that allows you, as I said, to automate processes, pre-hospital care, basic healthcare unit, ambulance, providing all the screening. Well, if there is a stroke, infarction, trauma, with a part of regulation automated based on resources, whether public or private, and we have specialty appointments for the sort of tertiary destination. So we try to get all the data, metrics, information on the patient, and having also some predictive models. So telecare and APH, we have certain validations with major customers from roadways, highways, cities like Sao Paulo, and we have an important landmark because today we can, for example, deduct the referral time of those victims to hospitals. So we can be 10 minutes shorter. Those working with emergency, this is super important because one of the modules of our service for the drivers that is at the upfront, that's a major player in this scenario. And today we use a navigation system that somehow provides the best path or journey, so the time they should take based on that navigation system. So we bring that to users. So users increasingly get to destination faster because they know they are being monitored somehow. At the same time, the healthcare team of these units, basic ambulances and basic units and secondary hospitals, we allow them to collect data. We work with multi-parameter models, we guide them to what to do, and we tell them which patients should be referred to, say, higher level hospitals. So we have this sort of health network, so we avoid unnecessary transportation and obviously reduce costs in a very drastic way. For example, we have 40% reduction of transportation that could be avoided. Actually, you can provide support. Patients know they can stay where they are, and there will be a doctor that will see them if we avoid the overflow of higher ticket hospitals, because it's a lot of spending for the operators. When we have the system more verticalized from the pandemic, we made an experimentation with tele-COVID, which was a platform for the population, so that people could be in an anonymous format, could input data and have guidance from healthcare professionals day-to-day, capturing clinical data. We ran this solution in Mexico. It was translated into Spanish, and we sold the service in Mexico. Here it was certainly free of charge. We had over 4,000 tele appointments, and with that we understood the population service, and we had the telecare and a clinic, which is a platform built by WeCare, and we have our proprietary streaming, and we have our proprietary medical system according to the National Council of Medicine, so according to ordinance, there's and all the record and geolocation data, etc. So our time was, well, we thought we need to combine both into a single product. We understood that the doctor that regulates pre-hospital care is the same doctor that can have that specific visit. So we managed to create a workstation. So we are actually combining products in the medical system as a service. We can provide the software at the front that actually screens people and process for example, populational care, be it in a booth, in a pharmacy, or direct care to people. And the doctor that is at this workstation can provide support to any kind of scenario. So we ended up understanding that the doctor was the main player in this whole process. And then we can provide not only the software up front to teleappointment or pre-hospital care, and we can also sell the service as a whole. So today we work with the scenarios, and we have clients that use both products, both for their rescue ambulances and also for home care, and they have that. And so we have, in fact, these two products, and obviously the doctor that is there, they can tell whether the patient has come from emergency, they have clinical data, and they can refer the patient to tele-appointment for the patient, regardless of where they are coming from. And what's interesting, as I said, it's really nice to visit to Rafa, and I know Steve lives, and we actually exchanged a lot of ideas last year. And we understand that data is very important. So we can actually today regulate the whole process. So reducing 12 minutes on average of referral of those patients, the cost of necessary referrals and final also because they get to places, to caring units earlier, and they are better cared for. This makes total sense in health. And certainly the startups must have not only focus in reducing deaths and disabilities and also impact to health. So in fact, we have combined the two services into one. And that was something we had in mind when we talked in the past. That was not very clear to us, but this is very clear now, because now we have clustered both services into a workstation to provide service, urgency, emergency, or just occasional care. Perfect, Jamil. Sometimes I hear people saying, I have the health WhatsApp. So there's a health, created health, Facebook of health. The other day there was somebody talking to me. He said he was creating the SUS of health, so the National Health System of Health. I was trying to understand what he was trying to do. Have you heard when you talk about the value proposal? Well, he didn't want to tell me what it was. It was a secret, he said. And when you start talking about the value proposal, we care. So it seems to be a bit like urban mobility of health. So you're shortening distances, times, and you're connecting right accounts in this crazy world and saving lives. This is the feeling I get, more or less that. Well, man, we don't like those terms very much. We are an ambulance Uber, as somebody once said. You have many more ambulances that are active than ambulances that are actually parked. I had a live with people from 99 taxi services. People said, I've ever thought about having an ambulance. They said, no, not at all. Well, man, we started, we didn't want to have, and then we said, well, look, well, to undertake is our purpose today is regardless of the term, is it's a base, Uber, whatever it is, to us it doesn't make very much sense because it's difficult for you to extrapolate all of that. It's basically an extrapolation. People say I'm iFood or something like that. So I think these health extrapolations end up bringing some data that is not very true, in my opinion. Nothing against, really. I see very colleagues and we laugh together, but we understand that what we're doing in this scenario is something really different because we don't use telemedicine as an end in itself, but we use it as a means. It is a means to provide support. For example, 50% of the APH nurses provide tele appointments because so there's screening, automation, regulation, and that itself is allowed for the health professional that is there as a specialist to make the correct decision. So in half the cases, on average, they have a teleconsultation, which is extremely valuable because you don't waste time, you don't spend human resources, medical human resources, which is expensive as well, especially in an urgency situation.
So I don't know if we're like Uber or Waze or if we're a combination of all that, but I know that we're having an impact because we're bringing into the healthcare market the perspective of emergency and urgency patients, which has never before been seen. The current systems that do that now, they exchange emails, or I mean, there's no data science for that. It doesn't generate any metrics. Our form is a three copy form with carbon copy that sometimes it's unreadable. And we created a fully digital form, but it's legible and with data that is entered. I think we're a bit of everything. And it all goes down to, well, in nature, nothing is created, everything is transformed. Many companies preceded us with innovative solutions, whether it is Waze or Uber or a bit of everything. Well, I think that what we've been doing is really nice. And now we're looking at medical regulation according to the needs and and regardless of where the patient is coming from. So these comparisons do exist, and maybe Rafa is, I don't know, Rafa, you're the iFood of blood banks. I don't know, but we don't like these labels because, in fact, I think that healthcare is a very peculiar segment where I don't think that these companies would be able to do really the things that we are doing, which is in fact really specific and extremely differentiated. Well, I can compare that either. Now, data science is pretty new. There are a few companies working with that, so I wouldn't be able to compare that. I think what we've been doing is extremely innovative. Istvan, I think that you froze for a bit and now you're back. Can you hear me now? Yes. Well, I was just told by the organizers that we're supposed to wrap up. Well, it's impossible to talk to two people with so much content like you guys for 40 minutes only. I could spend hours talking to you about this subject, but we'll have the chance to do that for sure. And I want to once again thank you for your presence.